toward adults like you do about kids. Because that's just my bread and butter. I started at Primary Children's when I was 20 years old. Back then you could graduate from nursing that young. And so now that you've done the math, yes, I'm about to turn 50. I did travel nursing for 6 years though, and I was able to travel through pediatric hospitals all over the country. Washington, D.C., San Francisco, San Diego, Denver, Colorado, all sorts of places. So I got to see how they do it all over the country. We do it the best here. I am not even a little bit biased, guys. We have the most equipment, the most support, the most community, most evidence-based community production of research, and we are really lucky for our pediatric care here at Primary Children's, because Primary serves 5 states. Nowhere else in the country do they have that large a catchment. So we are really, I'm totally braggy about Primary Children's. For 11 years at Primary, I was their trauma charge lead. They have a group of nurses that are specialized in trauma, and I was the leader of them, which was a lot of mentoring and a lot of education and teaching. But after about 20 years in that business, I was bored. Because don't we all get bored? We go into these businesses for adrenaline and we get bored because we are doing the same thing over and over. So 10 years ago, I also stepped into a new role with EMS for Children. This is a federally funded program within the Bureau of EMS, and they're all about developing peds education for the, sorry guys, for the Bureau and for our first providers. So you guys, so we have been educating and teaching for years and years, going around the states, doing conferences, but most often we do send out education through newsletters and through lecture series that we do. So I'll be referring to those things a bunch. I do still work 1 day a week in the ER at Primary because that's my passion and that's where I love to be. But this education stuff allows me a lot more flexibility to take care of my twins at home. So let's talk about kids. Maybe. Maybe.
Is it on?
It's the one that was here?
Yes.
Yeah, that's the one, right? Have to be turned on? It's just the one to plug into here.
Oh, yes.
I have my own.
This is like
Attention 51.
Oh, see everybody.
At 1448, West 1651, number 1.
Exactly what happens.
You know what? I'm well aware. And not you guys, not just you guys. I mean, it's happened, I think, with each one of our lectures today, or with here, but it happens all over. So, and you all know that you want to go and see what they're seeing and what they're doing.
No.
But let's over it. Okay, good. All right. Well, guys, what are you going to see? This was taken from the Bureau's stats this year, or for last year, the last 5 years. So when you get called to a 0 to 18-year-old kid, you are mostly seeing interfacility transports. And that includes all your behavioral health transports over to our mental health. So you've got that biggest section of your pie for peds transport is transfers. Then we have our motor vehicle crashes, our breathing problems, our seizures, and then a bunch of things that I don't even know why they break it up into these categories, because let's be honest, all this is trauma. So why don't you just put it all under trauma? So I kind of did. A couple of years ago I did this, and then I've updated every so often. Now when I first started this role 10 years ago, our trauma slice was 75% of the pie, and our medical slice was 25%. But here's where we stand now. Why?
Education.
I love that. Our prevention efforts are working. All right, we're actually doing things like safer laws for cars, seat belts, helmet laws, things that are keeping kids on the street after their traumatic injury rather than having to transport to a hospital. So that's cool. Our prevention is working. Why else?
I think this. EMS education.
Education absolutely helps. but you got it right there. How do kids spend their time?
Gaming.
They're not going outside, that's dang for sure. All right, we have kids that are now being treated for a gallbladder and gallstones. We have kids that have diabetes, type 2 diabetes. We do not have kids that are breaking their arms in the summertime as often. We used to have at least 2 to 3 fractures at primary children's a day. Now we are 2 to 3 a week.
Now it's arthritis.
And always on Friday. Always.
So fast. It's gonna be carpal pedal.
You're not kidding. So, kids are not having good summers, in my opinion. If you are not broken your arm by the time you're 10, you have not had a good childhood.
Dang it.
The most more though.
Knock on wood, because my kids have not yet. But my kid did split his head open this summer, so we're feeling pretty good about our childhood. But they're not getting outside, all right? And we have lots of reasons for that, but mostly it's entertainment, it's screens. I limit my kids to 2 hours a day maximum, and my entire rest of the day is them begging for some kind of screen in some way or other. It's so frustrating. So getting kids outside, we know the health benefits, we want them outside. Obviously we don't want them traumatically injured, but this is a sign or a symptom of a bigger problem. So here's some statistics. Trauma is still the #1 killer of kids in the US, and the quality of care that you deliver on scene, that I deliver in the ER, is actually going to impact their outcome. All right, it makes a difference what we do. Infants and toddlers, it's usually related to falls or abuse, unfortunately. And older children and adolescents, it's still related to automobiles. However, you guys all are, I'm sure, aware that in the last 3 years, the #1 cause of children's deaths, 10 to 17, is suicide. So still a traumatic death, but it used to be cars forever. Cars. And now firearms has taken over cars, and firearm homicide and firearm suicide together are the biggest thing that are killing our kids. So children's anatomy and physiology makes them more susceptible to certain serious injury than adults. So you got this kid here. What is it about his anatomy? His
Big ol' head.
Yeah, all right. Disproportionately larger head. Okay, kids are long darts. You throw them in the air, they will turn and drop and fall onto their head. They will land on their head. Their head is the largest and heaviest part of their body. So no matter how they are injured, their head is a consideration. And their neck is underdeveloped, cartilaginous. Can never say that word. What does it mean?
Cartilage.
Cartilage. What is cartilage? Soft, spongy stuff in your nose. But when you're a child, almost all of your bones are made of it, including your ribs, including your spine, including all that holds up your neck. Soft and spongy, because we're still growing, especially when we're little. So we're growing, we haven't hardened and calcified our bones yet, which means that their injury patterns are going to be a little different. I could get whiplash, and I might break a bone. Deformity. A kid can whiplash just as hard, totally bruise or damage their spinal cord, but their soft, squishy bones, no injury, no deformity, not even some swelling. Oh.
He's got FOMO.
No, bring him in. Pet him. All right, what else? What else about the kid's body makes them more susceptible to serious injury? We talked about ribs. Why would soft ribs be a problem?
So much.
There's no organ protection whatsoever. Here's another thing, size of our ribs, okay? My ribs come down to here, which means my heart and lungs and most of my liver and some of my stomach and all that is protected. A kid's ribs start here, and all their organs are in this big fat belly. All right? Cutest little belly ever, but it's full of a bunch of organs that are not protected. Then we have the soft chin or chest walls. We don't have the muscle or the ligaments that an adult has to keep organs in place. And then we have this little thing, compensatory vasoconstriction. Fancy words. What do you think it means?
Go until they can't.
Really well.
They compensate really well, but they do it like this. All right, I've got a healthy heart muscle, not like an adult who's had, bacon every day for their whole entire life. I have a healthy heart muscle and I have healthy vessels throughout my entire body. So when I'm in distress, the first thing I'm going to do is speed up my heart rate to pump my blood everywhere. And I'm going to vasoconstrict all of my outer vessels to keep my blood shunting to my organs. This is an incredible, amazing thing that kids can do. But it makes it so they look a lot better than they are. And they compensate. Once they lose that ability to do that little bridging, then they're over the cliff and you didn't even notice it. So that's one of the problems with them being seriously injured, because they can hide it really well. What's the first I just gave it away. What's the first blood pressure? What's the first vital sign that you look at when you get to an adult case? Blood pressure. You're looking for stability. For kids, blood pressure doesn't tell you a whole heck of a lot. It is the very last vital sign to change when the kid is distressed because of compensatory vasoconstriction. All right, one other thing, pliable bones we talked about. One other thing is larger body surface area to mass. This means a kid freezes a lot quicker. All right? That's a good thing if they're in an avalanche and you want to preserve brain function or cold water drowning. It's a bad thing if they're in your ambulance and you've had to cut their clothes off for some reason and they're freezing to death. Because remember our triad of death? Hypothermia is that corner. So if we do not address hypothermia on scene, then we are going to have a higher risk for that patient of dying from trauma. Questions about any of the anatomy? All right, now we got the brain, the actual psychology. Kids are less mature than adults. Is that a shocking statement? Did you know that they have underdeveloped judgment, and statistically it's especially in boys?
No.
All right.
Sometimes that doesn't change.
I just got to tell you, out of the womb,
When you say they
That's
out of the womb, women are more mature. And then they have lack of experience, okay? I know that if I go and touch that stove, it's going to burn my hand because I did it sometime when I was 5 years old. That kid hasn't had his 5-year-old experience yet, so he's going to go do it. All right? They are just curious, and they have no experience, and they haven't learned yet. So between the anatomy and the physiology and the psychology, we got kids that are traumatically injured pretty seriously and often. In Utah, we don't see a lot of penetrating trauma, though. We see mostly blunt trauma with kids. In some of our bigger urban areas, California, New York City, you're going to see a lot more penetrating because of gun violence or gun injury. But we're not supposed to call it, we're supposed to call it gun, I don't know what I'm supposed to call it. You all
Like
know.
homeless or urban campers.
There you go. Whatever you're supposed to politically correctly call it, it's gunshot injuries that are the reason they have more penetrating trauma. We, unfortunately, so far, are lower on the national scale for that, but it's not, it's a growing problem. Number one reason our kids are dying. But most of what you guys will see in Utah is going to be blunt pediatric trauma. Okay, so now we're going to talk about injury patterns. When you have a big head, you're a lawn dart. You get thrown up, you're going to land on your head. So that means that if I get hit in the chest, I'm still going to have a head injury. If I fall out of a tree, I'm still going to have a head injury. Now, if a woman falls out of a tree, well, like me, our weight and center of gravity is our booty, so we're going to land on our booty. Men will land typically on their shoulder and chests, but a child is going to land on their head in some form or other. So we've always got to think head and neck injury in kids for everything. So you always start with a pediatric assessment triangle. This was created by EMS, guys, and it has been moved into every other healthcare modality. It's been adopted by PALS and ATLS and PTLS, but it was originated in EMS. It's a fantastic tool. I use it every day at the hospital. This is my triage. The minute that kid walks in the door, I perform a pediatric assessment triangle. And it tells me everything I need to know about that kid. What am I looking for in appearance?
Their
behaviors, how they're acting,
How they're
they
acting.
look.
How else?
Skin color.
Skin color. Yeah, their general pallor, appearance. All right, there is a mnemonic for it: tone, interactiveness, consolability, look, gaze, speech, and cry. They actually put skin color, it straddles circulation and breathing, but it would go in here too. You're not going to be separating each one of these out when you're first looking at that kid. What am I looking at for work of breathing?
Is it there?
Okay, effort,
Accessory muscle.
accessory muscle use, and sounds, things I can hear across the room. Nothing I'm having to touch him with. I might at that point ask mom to pull up the sheet, pull up the shirt, to look at their chest and their effort, but mostly this is something you can pick up across the room. Little note on retractions: kids always work their way up. So their first level distress is here, their second level distress is here, and their real big red lights and sirens warning signs are here if they're grunting and nasal flaring. So if their retractions are working their way up, you've got a progression of respiratory distress in kids. Okay, so as we just said, what about circulation? How can I assess circulation across the room?
Blue, pale.
Cyanotic, pale. So that would be your appearance there. And then the other thing that's really big with kids is modeling. You guys know what modeling is? So if anybody has an infant, they know what about modeling. But what kids do, it's a lacy appearance. It's like a red blotchy, white and red blotchiness. I need to put the picture on there, I keep forgetting. And it means that I am shunting all my blood to my organs. So I'm going to the core and I'm leaving the extremities out to hang. And it means I'm in distress because there's some reason that I'm shunting my blood to my organs. All right, so if you walk in on a kid, you see that. Now it's a baby. Baby have unmature circulatory systems, so they just model at the snap of a finger. It's usually because they're cold. You might wrap them up and then check again to see if you've got persistent modeling. But with a kid, a 5-year-old, 6-year-old kid, if you see modeling, that is a compromised circulatory system. So the way you use this PEDS triangle is in your book for your PEP and your EPC courses. It says if you've got one area that is abnormal, that's a sick kid. If you've got 2 areas that are abnormal, that's an unstable sick kid. And if you've got 3, that's a scoop and run. All right, so if 3 areas are compromised here, get moving. That's kind of like boiled down to the basic. Now, when it comes to trauma, it's important to have a trauma process for assessment. But all PEDS assessment starts with this. All right, this is where you start. You make your sick or not sick determination. So now you go in and you pick your trauma process. And there are like 5 million of them, and it's really silly that there are because there don't need to be. For generations, AHA, American Heart Association, put out the ABCs. All right, we always ran kids or traumas on ABCs. And then we got ACLS and PALS moving towards some of the more military tactical stuff. And so now we have March, and I believe that's what you guys use. And March is another variation of this. And this is basically, I like this one because it includes the PEDS triangle. But they're all the same, and whatever you use works. Always use one, though. Now, back about 3 years ago, they moved to CABC. Why? Why did we do that?
Stop bleeding.
Stop bleeding.
Because we had a big body of evidence, unfortunately from school shootings, that showed that people were dying on scene from bleeding out, not from bullet wounds. They were not dying from the injury itself, like they didn't hit major organs or it wasn't direct into their brain or heart, but they died because no one stopped the bleed. And so that was a national movement to get people lay people to act when they saw a lot of blood, which was like something they'd moved away from forever, hands-only CPR and all this stuff. And it's like, now we want you to dive into their blood. So we're kind of backwheeling. But this one I like because it's got the PEDS assessment triangle, then you've got your bleeding, then you've got your A, B, C, D, E, and each one of these is reevaluate, reevaluate, reevaluate. But whatever you use, and if you guys are still using March, which is awesome, it's the same thing. It's all the same thing. But always use a process, because that will help you organize your thoughts when that child is in need and your adrenaline is pumping. So let's move through that process as far as it comes to peds. You guys mentioned it, Stop the Bleed. This is a fantastic course. It was produced by the American Heart Association. It was put out for people like us to become instructors by taking the course. So if you've ever taken this course, you're automatically an instructor because of your medical background. Then you can take this course and push it out to the community. And this is something we really have statistically seen saves lives. People who know how to stop a bleed on scene are saving lives. So we're really encouraging our EMS agencies to make sure that you're all certified. As instructors, it's super easy, just take a class, which you can set up through Jared right at the Bureau or through Primary Children's or IMC, and then take it out to your community. When you guys are doing community fairs, take the flyers for this course. It's all free and everything else, but this is a way for people to understand how to stop the bleed. And obviously when you approach your patient, you've done your pediatric assessment triangle, you want to stop the kid's bleed. We'll talk about why in a minute. Not that you don't know, you know, but I'm going to talk about kids. So you manage exsanguination, you carry around your tools for doing that, and you know how to use them. That's all we ask for. So then moving on to pediatric airway, okay? So the pediatric airway is a fun topic. There's two things that influence their airway just at baseline. What are the two things?
Structure.
Their head and their tongue. All right? The structure of their head, this occiput is huge until they're about 5 years old. Which means that when I lay them flat on it, it immediately goes like this with their airway. So we talk about the towel roll. You guys all know about this. And in trauma, we encourage a jaw thrust maneuver rather than a head tilt because we have a child who's probably landed on his head or had it whipped around a bit, and their unstable neck is probably going to be at risk. So this is why we do our jaw thrust. Now the tongue is monster. It's huge. And at baseline, if this kid is relaxed at all, it is going to fall in the back of the throat and occlude your airway. So some things to think about with kids is a very underutilized adjunct with which your last crew told me y'all use, but I never see it at primary, brought in by EMS, never. So what is it? OPA and NPA, okay? A kid, holding up a kid's airway is a two-hand job. Just to lift all the baby fat and all the slime that's going out of them. It is a two-person job at Primary Children's. We have two hands on that jaw, two hands maintaining that thrust, two hands adjusting between every single breath because it's a tough thing to do. And then you have someone bagging. You guys don't have that luxury. So don't forget to use your adjuncts. If the kids, once you pop that OPA in, then it's a one-handed job for the most part. You've got good towel roll and you've got an OPA in with a good sedation, or the kid is obtunded, and then you can bag that kid with one hand. So that is something that we really encourage. The other thing is bagging is the superpower pediatric skill. All right? If you can bag a kid, that is your most valuable tool in your pediatric toolbox. And it's not completely like, oh, any idiot can bag. You need to practice it. It's a skill you need to put hands on. It's a skill that you need to practice regularly to be good at it. But if you're good at it, and especially if you know how to integrate it with a ETCO2 monitor, then you have a superpower when it comes to kids. We'll talk a little bit more about that. Airway, though, kids are really good at maintaining their airway, even in respiratory distress. They really, that compensatory ability, because they have strong lungs and good muscles and all accessory muscles, they really do well with their airway. They do a good job keeping it open. And you should let them do it as long as they can, even in scary situations. Okay, I put this slide in, I can't remember why, but now I remember why. Okay, intubation or not intubation? That is the question. Now, You guys do not do RSI for kids, I understand. We only have a couple of agencies that are trialing it right now, and I can tell you the trial is not going well. So, statistically across the board, EMS in Utah do not have good success rates in intubating kids. They do not. Even the ERs across the state do not. And primary children's only has 60% success rate on the first pass. Intubating kids is really hard. There's a bunch of studies that show, and this is one that's citing one that they pulled out. Western Pediatric Trauma Conference happened last weekend. And I called the doc who presented this and said, give me that slide. But they showed a huge study that was done, and then they also showed this study here. The huge study showed that kids had a 3.54 times higher risk of failure than adults in the intubation attempts. And then it did a bunch of comparisons of ET tubes to bag valve masks to subglottics. And the results were, most studies found that there was no difference in survival with the use of ET tube, but they did find some studies that showed they had increased mortality with ET tube, so they concluded that there was an equal or worse outcome for the use of ET tube when compared to subglottic or BVM. Now this is a complicated slide, and it was a complicated lecture, but that lecture is going to be presented to the EMS committees. And we're just pushing that, guys, if you can bag, if you're getting good response from bagging and you don't have a crazy long transport time, which none of you do here in Layton, it took me 10 minutes to get here today, and you get lights and sirens, bagging is what we would really encourage. If it is a situation where you're like, I need to intubate, then intubate. We're always going to defer to your clinical judgment and your experience. But whoever is intubating needs to be the person that's the very, very best at it and the most comfortable with kids. And since you see kids once every 3 weeks, it's really got to be a well thought out thing. So what we encourage currently is really, really get good with bagging. Practice it. Bring in your children and let them practice it on them. They actually enjoy that. My 8-year-olds love to be our little mannequins. And get good at it. Get some good technique and understanding of how EtCO2 works with it. And then find a good subglottic you really like and start getting good with that. Just for kids. Go to town on intubating. If I'm dead on the ground, put a tube in my throat, please. But with kids, statistically, it's just not working, guys. And unfortunately, I've gone on 2 reviews in the last 3 months where a child has been killed by an esophageal intubation. And a head injury. let's go there too. And a head injury. But we just don't want to cause harm. Any questions or concerns about that?
What is it about the intubation that's killing them?
It's
Overpressurization?
I have that slide. Did I put that slide? I did put that slide in here. I have that slide.
Look at you.
So our biggest complications are right main stem intubation. All right, that's not the killer though. Esophageal intubation is the one that ends up killing. Right here, frequency of adverse events associated with pediatric reports. But this is where we go wrong. All right, typically picking the wrong size, dislodgement, and I think that is most cases. You know, we do these statistics, and I read your documentation. You have good placement. You have CO2. You have verification by EtCO2 monitors. But I think it's the movement stuff, because by the time they get to the hospital, that tube's no longer in place. So that statistically affects us. Then intubation in the esophageal intubation, right main stem, and then cardiac arrest during the process. That's usually more a case with RSI. And then tracheal injury. That is a lot less common.
Are you seeing more like with let's say like a 3.0 cuff tube compared to one that's uncuffed, or is that like part of the?
When we do our airway, our difficult airway courses, we actually encourage you to use a cuff for all pediatric patients, because then you'll have the option to close an air leak, and the cuff doesn't hurt if you don't have an air leak and you just keep it deflated. That's fine.
That's
So we
what I
still
was just
encourage
wondering,
it.
like the tube dislodgement stuff, I know it's bumpy and stuff in the back of the ambulance, so that cuff, you know, I mean, an incorrect size tube will.
Can keep
right,
it
probably keep
secure.
going, But
Mhm.
the cuff.
And use the tricks that you know, and practice it too, guys. Do it when you need to. I don't want to scare you off of it. It's within your scope of practice, and it's your clinical judgment. Do it if you need to. But take a moment and think about it. If your kid is bagging really well, why? Why do it? Why put them through that risk? Okay? So just a thought there. Now, airway. Back to airway. Oh, conclusions. I put this, you know why I put these slides in? Because literally last weekend, I was like, send me these slides. But we had a lot of discussion about it last group, your group. So I wanted to kind of bring it in for that purpose. But sorry, I keep forgetting that I put these slides in. So mixed data, best practice in pre-hospital management suggests that BVM first, subglottic, and then intubation would be your way to go, and then just really get comfortable with whatever your agency chooses to use. Know your pros, know your cons, and get comfortable with the tools that you have available. That was kind of the big overall conclusion of this doctor who presented to all the trauma surgeons on the West Coast, Western United States, and talked about this specifically. So those were the conclusions that they came to. And then the big one too that we're going to talk about is just monitoring, all right? Whether it's bag valve mask, subglottic, or intubation, monitoring your ETCO2 throughout your entire transport and making sure that that tube is functioning the whole time through. That's huge. All right, this is what I kept thinking we were coming to. This young man is a 10-year-old motocross injury, impacted the crash, broke the helmet right here, and it swiped across his jaw, Joker style. He came in, no loss of consciousness, he was alert, which likely saved his life from the scene, and EMS allowed him to remain in his own position of comfort. So even though he was in a serious injury and his helmet had been damaged, they let him sit up, which was really good and appropriate for this situation. So in our trauma bay, we also kept him in position of comfort. We evaluated him and went straight to the OR, and then we did a surgical airway while we were sedated. Like, we did his nose for his anesthesia, we put him down, and then they surgically placed an airway. I did the trach, which was really effective. So with kids' airways, if they're maintaining well, let them do it. Even at the expense of, you know, some of your more stringent spinal immobilization stuff, as long as you can stabilize them well, just let them maintain their own airway. If, however, this kid was unconscious, then you'd have a whole nother scenario. This would be a kid that you would likely intubate on scene. Or perhaps try a subglottic. He'd be a good candidate for a subglottic because all of his injury was here in his face, not necessarily down below. But being familiar with needle cracks, surgical crack trachs, that's kind of the route we go. He actually had a beautiful outcome. They did a great job with his repair and did very well. So just be aware of those. Okay, whenever we talk airway in kids, we also need to think spinal immobilization. I know that standardly we have moved away from this in adults. We've learned that backboards cause bed sores, and we have learned that the C-collars and stuff are annoying, and everyone thinks that too, and so do kids. But we talked about the soft neck. We talked about the unstable neck. So with that together, we need that kid to still be in spinal percussions and a C-collar. Unless you don't have one. Does that C-collar work for this kid? No, no. We want this neutral position we really like. We also like these ones that are Miami J's. They're a little more permanent. That's what we send the kid home in. Go ahead and use your neck lock or whatever you've got on the board. But we also know that we can use what? Towels. I love a good towel roll. Towels work fabulously if you don't have the equipment that you need, and we also especially like when you tape it, the forehead, and just whatever immobilization. But we do need to think about neck whenever we think about airway in pediatric patients. And I would say probably, I think what they're moving to is 8 and younger for this, because after that you do sort of calcify those bones in the neck. But your protocols say kids, so 18 for this point. Here's the other thing on the spine. The towel roll is fabulous for the airway. doesn't do much for the spine. So in fact, what we really want to see is a blanket all the way down to the booty. And you'll note that the pediatric backboards have that pad in that place with the cutout for the occiput. So the pediatric backboard is really preferable if you've got a pediatric patient. We have a ton of them in storage at Primary Children's that have been abandoned by agencies. So if for some reason you're missing them or you don't have them on your ambulance, come grab them. We would love you to clear out our storage. But all the way down for a neutral back position. Okay? All right. Now we'll talk about breathing. We talked about accessory muscles already. So here's the thing with compromised kids. They have a higher oxygen demand. They burn oxygen faster because they have a higher metabolism. Which means anytime they're compromised, even with a broken arm, you should probably be considering oxygen. Because anything that's circulating needs to be saturated so that they can do what they need to do. So kids with trauma should have oxygen on. What's the best way to put oxygen on a patient? A pediatric patient.
Blow my soul or blow back.
No! This is a soapbox issue for me, just so you know. Blow-by will jump your SAT monitor up, which is great. So it's doing the job. But it's not measurable. And you cannot tell me how much distress the kid is if he's responding to blow-by. What I really want to see, what we want to see at primary, is a measurable device. So what we've pushed to have on ambulances is a nasal cannula, because kids actually tolerate them really well. Here's the trick. You put the sticker on the tube right next to the prongs. You put the tape or the sticker on it. Then you go behind the kid and you loop, the neck loop over the kid's face, and you stick it into his nose and stick it onto his cheeks. And then you step back, and mom's holding his hands down. And then he's like freaking out because he's got it on there. But then you slowly turn that oxygen up. It's the blowing of the air that freaks them out. And if they've been freaked out, they're not going to tolerate it. But if you do it in that process, stick it to their face, give them a second to calm down, and then secretly edge the oxygen up, they're going to tolerate it a lot better. And then you're going to, in report, tell me, hey, this kid needs 2 liters of oxygen to get that SAT of 96. Whereas that's far more valuable to us in delivery than a blow-by. Blow-by works. Blow-by will knock up the numbers. But on a long transport, especially, you can hook a ETCO2 onto that, or to that nasal cannula. It's just such a better, more effective way of delivering oxygen to the point of a compromised patient. And it's harder for us to rip it off as soon as you transport them onto our gurney, which happens to the non-rebreathers all the time. In our video reviews, everyone's like pulling off EMS's non-rebreather and then transferring him, and then somebody forgets to put it back on again. And that's so frustrating because these kids need oxygen. All right, when it comes to circulation, you got to think about volume. Kids have less volume than adults. So a toddler, an average toddler, is walking around with about 4 cans of Coke of blood in their body. Which means if you show up on scene and you've got 4 cans of Coke on the ground, an adult, that might not make you blink at all. But a kid, that's dangerous. That's almost all their well, that is, in a toddler, all their fluid volume. So how do you look at their circulation? You're assessing their peripheral pulses against their central pulses. These are central. This is your baby central here, femorals. If there's a difference, if a child is fretful or lethargic, that's one of the signs their circulation is compromised, because they're shunting to their organs, not their brain. They consider their brain like their arms and their legs. They start to move the blood to the core when they're compromised. So they become irritable, they become fretful and lethargic. And then they eventually can't sustain their blood pressure, especially if they're losing their volume. So that's when we start to see blood pressure problems. If you see a blood pressure problem in a kid, we are over the cliff. What is the normal blood pressure for a child? Don't look at this. For a child that is 6 years old.
For systolic?
82.
I like 82. That's a good formula. What's the heart rate for a 6-year-old?
Yeah, shit.
Heart rate max. Heart rate max. 140. Here's the thing, guys. Pediatric nurse, 30 years. I don't have these memorized. I carry these on a lanyard every time I work a shift. But I need to have some kind of reference on hand to know if it's abnormal or not. I look for tachycardia, because tachycardia is my first abnormal vital sign when it comes to distress in kids. And I don't know tachycardia or not until I look at my vital signs parameter for that child's age. So you need a tool, whether it's a digital tool or hand-tivy or the Broslow or a pediatric vital signs card. But you should have this available to you. Because if you see that tachycardia is abnormal, and then you know, okay, I've got some problem. First thing I want to do though with kids is rule out 2 common causes of tachycardia. What are they? Pissed off. No. If I've got a calm kid with tachycardia, I'm far more concerned than a crying one. So yeah, you want to see if the kid's pissed off. And then what's the other thing that causes tachycardia that's relatively benign? I heard it. Fear. Oh, fear. No, I thought I heard it. Starts with an F. Fever.
I said fear.
Fever. All right, so this is a big one too. Fever causes tachycardia. I cannot truly assess a kid until that fever is gone. So the family that brings the kid up and says, "Oh, I didn't give him any Tylenol or Motrin because I wanted you to see the fever." Then I say, "Well, you just added 30 minutes to your visit because I now need to treat the fever and get it away before I can assess your child." So if you guys are on scene, please ask, and you notice a fever, please ask the parent to treat it before you leave. Because by the time it gets to the ER, then we really appreciate being able to see if we have tachycardia in the absence of crying or fever. If I do, then I have a kid in distress. All right? So that is going to change way before this one. If this one changes, then I got a volume problem, especially in trauma. Then I've got a volume problem or a shock problem. But either way, that's how you got to approach vital signs. And nobody's going to memorize all these numbers across all these boards, especially because they change them a lot too. Like PALS cannot decide what is the backs. So make sure that you always have a reference of some kind. There's plenty of good online references as well. Our goals for treating is no longer to wide open bolus everyone like we used to. If you guys have been in the business long enough, it used to be everyone, roller clamp open. Kids, roller clamp like that much open. Everybody still gets a line, everybody gets warmed, whatever, but not everyone gets bolused. Right now, the management of circulation is always to stop the bleed, to maintain or restore a blood pressure. If it's using crystalloid, then yeah, you'll start with your 20 per kilo. We move from 20 per kilo to blood in trauma. We don't do 20 per kilo, reassess 20 per kilo, reassess 20 per kilo. You guys are still doing that because you're not carrying blood yet. That's a yet. But when you say, I'm giving blood because I am concerned about bleed or shock or whatever, we're already activating our blood bank, or perhaps our MTP. And when we do our MTP, which is our mass transfusion protocol, then we will get a 1-to-1-to-1 of platelets and red blood cells and cryo, and then we will transfuse in that manner over and over and over again until the kid is stable. But we don't want to overhydrate with NS. We want to replace what's being lost, and if that's blood, then it needs to be blood that we replace it with. So we're moving to that quick. So how does this change your practice? Not a lot. You're still doing 20 per kilo, but if you are doing 20 per kilo, you're telling primary children, hey, we've already started bolusing this kid. That's going to change what we do on our end, because we're going to get to blood a lot faster. When we do blood, oh, and I didn't fix this slide. Roxanne needs to send me an email. It's supposed to be mils, obviously. Mils per kilo. All 3 times I'm like, oh, we got to do that. All right, moving on to disability. We have our kiddos. We love a good AVPU. AVPU's awesome. We appreciate it. However, a pediatric GCS score helps us to determine a few different things. Basically, a score of 14 is 50% more likely to get a CT scan. 13 to 15 is mildly repaired kid that will probably fully recover. A kid 9 to 12 for more than 30 minutes will have lasting physical and cognitive impairment, and a score between 3 and 8 are usually associated with poor neurological outcomes. And then, the classic 8 intubate kind of a thing. But these scores are modified for kids who don't speak, which is great. So these are kids that are little kids that can't tell you how they're feeling or giving you a good verbal response. So having it on your card and available is also really nice. But if you can give us a good GCS, it's going to influence the team that we have that meets you in the trauma bay. So that's helpful. But we'll take an AVPU if that's what you got. AVPU's awesome. All right, and then expose. You can't truly evaluate a whole body until you've looked at it all the way. I took this off a 10-year-old kid, world's greatest beer drinker. I was like, he is set up for a special life. But the biggest thing with exposure and inspection is obviously providing warmth. You don't have to strip every kid down, but you should look under every part of clothing. If you do strip them down or cut off their clothes, just remember to warm them up. There was a study done a little while ago, was like they took a temperature of every kid coming out of an ambulance and an airplane and a helicopter, and every kid was too cold, like every kid. But here was the funny thing. They would leave the ER colder. So we did like a terrible job getting them warmed back up. So all of us across the spectrum need to think about warmth, and that means warm blankets, that means bundling, and keeping them warm because of that large body surface area where they lose heat like crazy, always also through their head. So if you put a warm blanket on their body, that may not be enough. You might want to loop a little blanket around their head. They lose heat on their head, especially the infants. All right, now we've talked about our trauma process, our ABCDE. Now we're just going to go back and talk about the types of injuries you're going to see with kids, how they might be a little different from adults. Everybody doing okay? I know your attention spans, because my attention span's like 30 minutes. So if you need to shake around, do a little dance, it's all right. You know what? Lectures like this are going to be a thing of the past. We all know it. But I don't know any other way to do it. I like pictures. I like PowerPoint. So that's where I'm going. I got like 15 years left and I'm done. So I'm not learning new stuff.
Almost there.
You guys you guys can come up with a new way. All right, so let's talk. Number 1, pediatric death. Cause of death in trauma is head injury. No surprise to anyone in the room, I'm sure. We do have, that'll you need to think about with kids, is a golden hour. In the first hour after a head bonk, a kid might fall over, fall asleep, seize, vomit. I'm not that concerned. All right? Parents come in, oh my gosh, he bonked his head and immediately threw up, immediately fell asleep. Well, if it happened immediately, I am so fine with it, because that's a concussive thing. And it's usually self-sustaining, it's usually done, no big deal. If we're having those same symptoms after an hour, then I'm concerned. Why? Brain swelling, brain bleeding. All right, that, an hour after a head bonk, persistent symptoms, now I'm concerned. So when you arrive on scene, the first thing you want to do is get the time of the injury. And are you in that golden hour? If you're seeing symptoms outside that golden hour, that kid is much more compromised than the kid who just had a head bonk and an impact seizure. Impact seizures are self-limiting. They're usually not associated with worse outcomes. You can comfort the parent. They may still need to be evaluated for concussion. The cool thing about being evaluated for concussion at primary or one of the hospitals affiliated is that they get a ticket to concussion clinic, which means they can go and follow up if the kid has prolonged things, like prolonged headaches or prolonged learning difficulties or eye vision problems, everything like that. That's nice. So don't always release those parents at the scene if the kid seems fine and they're concerned. Then tell them, go in and take a look, get a look, because they might have long-term symptoms that need to be evaluated. But usually symptoms within the hour that have resolved, they're going to come to us. We're going to watch them for 3 hours. We're going to send them home. We're not even going to CT scan for the most part. We have a very specific protocol for not scanning kids that we don't have to scan. Because there's stats that show the younger the kid is scanned, the more risk they have for cancer in adulthood. So we've clamped down hard, and statewide. We've sent out TBI protocols for every hospital to avoid CT scans unnecessarily. So we're going to observe that kid for 3 hours, we're going to send him home with resources to follow up with concussion clinic. But here's the kicker. A couple of years ago, there was a study done at Primary Children's that's now gone nationwide. In 2023, they put it out in a format for EMS. But this is the biggest take home I want from this whole lecture, and we're going to bring it in a couple of different ways. They did a big old study on TBI called the EPIC study, tons of people, like 8,000 patients. They determined that the biggest impact we have in trauma care for pediatric TBI, which they've now moved to pediatric blunt care, pediatric trauma, like every aspect of trauma. The two things you have to recognize and treat are hypoxia and hypotension. If you do not recognize these and it goes untreated, every hour that it goes untreated doubles that kid's chance of dying. For every hour untreated, hypoxia and hypotension double the kid's chance of dying. So if it's 1 or 2 hours, you got a 6-hour transport, that kid's dead. However, if you recognize it and you treat it, then you increase the kid's chance of living by double every hour that you're doing that. This is huge, okay? And we talked about how you do that. So this comes from a protocol that was created as a pre-hospital protocol by the Utah Pediatric Trauma Network, UPTN, and we're going to refer to that protocol in just a minute. But let's do a case. 7-year-old, no helmet, unwitnessed ski accident, found at the base of a tree by a cousin. He had a questionable loss of consciousness. His vitals were stable. He was awake and arousable. He had a forehead contusion, minor face injuries, vaggy hematoma, that means soft, scully area, a GCS of 13, and a swollen tibia. All right? So this is your kind of case. You bring the kid in. He comes in as a trauma 2. We don't even activate him that high because he's awake and alert. And they do warrant a CT scan by the PCARN data, and they see that he has this little skull fracture right here. But he is waxing and waning. What does that mean? What is waxing and waning? He's awake and talking and untended. And then he's awake again, he's talking to you, he's asking questions, and untended. And oftentimes he's asking the same questions every time he's awake. But he's up and he's down. He's up and he's down. And this is an hour and a half after the original injury. All right? That is a warning sign for something. So he's admitted to the PICU, and they sit on him for about 2 hours, and his neuro exam gets worse. No longer is he up and downing, he's just down. So they take him back to the CT scan, and they see that his little bleed fracture, he had a little fracture. They didn't really see much blood. They saw this little bit of blood in the first CT. 2 hours later, it's here. This is an epidural bleed. It's now pushing on the brain tissue, which is affecting his subconsciousness. It's also pushing, you can't really see them, but they're pushing the ventricles. So we're getting pressure and swelling in the brain. So they had to go into surgery and relieve that blood. They drained that blood out of there, and then the kid did fine and was discharged post-op 4 days. So that's kind of your typical progression for an epidural. It can happen very quickly. It can happen in your ambulance. You can see that waxing and waning and then going to unresponsive. And that's a lights and sirens, get them there quickly. There's not much you could do. You're not going to bolt them in the ambulance, although they did some experimentation with that a few centuries ago. But we do not do that now. That is not recommended. Now, there's another kind of classic head injury that is slower. It's venous in origin. And unfortunately, it's far more common than even the epidurals. All right? So what happens in these scenarios is you have the baby who's shook because parents are very frazzled, And then you have the bridging vessels of the brain that break and bleed. Now, we cannot talk about trauma in kids without talking about child abuse, and I've got a little section on that here. But I'm just going to say, I was 42 years old when my twins were born. And I was a child abuse advocate for 20 years. And I wanted to shake my babies. All right? I wanted to shake my babies. I never understood it from their perspective until I was sleep deprived and I was tired, and I'm an old mommy with education. I was not at risk, except that every parent is at risk, and every parent will want to shake their baby. And so every parent needs this kind of education, that it is really dangerous to shake your baby. And so what do? You teach them that in that moment, you put that child into their crib and then you go beat the crap out of a pillow. And I did exactly that. I shook a pillow. I didn't beat the crap out of it. Maybe I did. But you protect that baby, you put them down, you walk away. And this is education that we're teaching them. Because here's the thing, guys. Let me back it up, though, because I want you to see this video, because everyone was looking at the shaking baby and not the video. Let's go back here. Look over here. Look over here. Ignore the shaking baby. Look at his brain. These two little things back here, they just rip. You think, oh man, that'll take a lot of force. That's the vessels we're talking about, guys. The size of a hair, which means that this one shake can do the job. And then the baby immediately stops crying because he's stunned. And parents like, oh, finally, he's asleep. Puts him down in bed and then calls you 2 hours later when they can't wake him up. All right? Or the baby's extremely fussy because he's got pressure in his head now, or he's vomiting. Okay, those are the things you have to think about that might lead to head injury. And if you've got that head injury, what do you think you got for the neck? Talked about that soft neck. So if you're suspicious of head injury, then you also want to stabilize that neck on transport.
So does this still fall under that same conversation we were having a minute ago of that golden hour of, say you have this child that has experienced some kind of whiplash, they immediately throw up, they're having some of those symptoms. Does that fall under that golden hour, or does that now turn into a different situation?
You're actually going to see these symptoms several hours or even a day or two later.
Got it.
So these symptoms are not going to show up in that golden hour.
So
again,
throwing up
if you've
after
got
something like that isn't going to be like, oh no.
Immediate. No, they're not.
Okay.
Well, they're not going to be immediate. They're not going to call you because the kid is vomiting associated with that shake, because they're not going to tell you about that shake.
Yeah.
They're going to call you because they can't wake up the kid, or because the kid is continuously vomiting and acting funny. The parent, they've known they've done it. They know they've caused harm, but they're going to tell you the baby's sick or throwing up. So that's why you have to, unfortunately, consider abuse in every pediatric call you go on. And we'll talk about this more with the abuse section, but I just wanted to focus on the fact that these bridging veins, they're easy to pop, and so any infant that you're going on any call, you need to think about NAT, non-accidental trauma, being a cause associated with it. It's just because of these two reasons. All right, this is that protocol that I was telling you about when it comes to TBI management. It's busy, I get that. It's also online and free for you to access at this app. This is an app that you can download. And it's got a whole bunch of things from Primary Children's. This group was a federally funded group that is trying to get rural communities to be able to keep their kids. Forever, everyone just transported to primary. Everyone, all over the 5 states that we feed, including Alaska. And the kids would come to us and we'd be like, well, we're observing you for 3 hours and sending you home to Alaska. Totally inappropriate use of healthcare resources. So this organization is here now across the state trying to get rural hospitals comfortable with keeping their kids. And protocols are the way they're doing it. This one, though, is specifically for pre-hospital folks. And here's the thing, it's busy. But you start over here, is the kid a head injury? Do we have these symptoms? Put them on monitors, you do that already. And then right here, this right here is those 2 things I told you about. Prevent hypoxia, prevent hypotension. So how do I prevent hypoxia? I do this. How do I prevent hypotension? I do this. All right? Really keep this in your mind when you are transporting a trauma patient, because if you can do those two things, prevent complications on those two things, that outcome for that child improves exponentially. All right? And not just TBIs. Like I said, we're already applying these to all of our blunt traumas. It's a little different with penetrating trauma. Obviously, your number one goal is going to be stop the bleed. But this is going to be your goal for all of your pediatric and adult traumas. Is going to be your overall goal. Roxanne's going to put it in your education resource as well. But this is the app. This is where you go to put it on. And all of the hospitals are linked into this. Every single one of them is a part of it. It's free. It's got a couple of other resources for EMS. They're growing that leg of the program. So good resources for you guys. And most of our medical directors have signed off on their protocols as well, because these are actually primary children's protocols that are just packaged for the state, so that every state can use them, or every hospital in the state can use them. Okay, so now we're moving to we did our head. We're going to just talk briefly about spinal cord. We talked about the whiplash that can happen without any deformities. This is skiwara. It doesn't happen in adults. It's spinal cord injury without radiographic abnormality. And skiwara is, I have a bruised, damaged spinal cord, but there's nothing on the x-ray. I can't see any bony deformities. I can't see any injury whatsoever. But I have an actual spinal cord problem. So how do I see this in my patient? You don't. You are going to go off of what the mechanism was, and these are the mechanisms that cause most severe spinal cord injuries in kids. So you got to think about that, your axial loading, your hinging forces. And then if your kid, for any reason, complains of numbness, tingling, weakness, paralysis, if you do see bony deformities or bruising or swelling, if they have midline tenderness, tummy pain, or if they've lost bowel or bladder control, or they're having trouble breathing and you don't have a respiratory cause, all of those can be symptoms of spinal cord injury without radiographic abnormality. All right, so that's a kid who needs to be transported, who needs to be immobilized and taken seriously. Little kids are not going to tell you any of these things, but if they do have, if they've lost their bowels or something like that, a toddler, somebody who has had control of their bowels, you may want to think about that. And let the hospital know, because it actually changes our trauma activation. We bring in our neurologists for spinal stuff. We don't do that for normal traumas. So if you let us know in report, that's super helpful. All right, number 2 cause of traumatic death is your thoracic injury. The funny thing about thoracic injury, though, is that it's never just one thing. Here's a case. It's actually a case from this area. 9-year-old was kicked in the right upper corner right upper stomach by the stomach by a horse, transported to a local level 4 trauma center, and she had developed sudden severe respiratory distress, and they couldn't bag her. She was really hard to bag. So they're like, grab an x-ray. They got the coolest x-ray I have ever seen in my career. And then she became unarousable. All right? This is at a rural trauma 4 center. This is the x-ray. Why is that the coolest x-ray I've ever seen? Is her heart supposed to be pointing in that direction? The apex of the heart is supposed to point down. Is her liver, which is supposed to be a triangle right here, in the right place? Is her stomach, which is supposed to be right here, in the right place? What is happening here? Don't look at the thing up there. This kiddo was punched in the chest by a horse and got a pneumo. That pneumo became a tension pneumo, which punched a hole in the diaphragm, and it became a tension pneumomediastinum. There is tension, air tension, building up in this entire cavity, and it's putting pressure on all these organs. How long does she have to live? Not long, because that heart cannot possibly be pumping much blood anywhere. All right, so this is the scenario. Level 4 trauma center. EM crew is in the room, paramedics. they said, paramedics, do something. What'd they do? They needle decompressed, which is a skill, guys, you are far more comfortable with than the ERs are, for the most part.
That's terrifying.
That is her x-ray post-needle. All her organs back, and this is a different x-ray machine, but all her organs back into a normal place with that needle in her chest. All right, so this is a skill I don't need to teach y'all. This is something y'all are versed in. You train on it far more than any nurses do. But it is a life-saving skill, and it's awesome, and do it. We don't needle in the ER. We go straight with our trauma surgeons to a chest tube. But you guys will save lives with this ability, and that's just something with kids. But here's the kicker with pneumos and kids. 90% of them, I'd say 99% of them, we do nothing for. They don't progress to tension, and they reabsorb. We just watch them in the hospital. And they reabsorb themselves. We don't even need to put chest tubes in. That's a pretty common occurrence. Kids do get pneumos for all sorts of reasons. But we don't usually do anything because they have healthy lungs. Their healthy lungs heal really well. Adults will usually need a chest tube, but a kid, we don't usually do a whole lot. So if you suspect a pneumo with your auscultation and your jugular veins, if it's a jugular vein one, you've got to think tension, and you have to weigh their ability to be stable for your transport. But most often you're not going to need to do this. However, saying that, in all the 10 years I've been working with EMS, I have seen like maybe 1, 2 sporadically. Like this year we've seen like 5. It's been very strange. So I don't know what's changed, but statistically this year is a big one for needle decompression in children. But here's the kicker with thoracic injury in kids. In adults, you got all that stuff all spread out and well-rooted and well-ligamented, and muscles and fat layers and hard bones. In kids, you got it all crowded into a tiny space with no protection. So you are going to drag your feet, remember this game? Drag your feet on the carpet and go touch somebody, and electricity just shocks right through their bodies. That's what a traumatic injury in a kid's chest or abdomen are like. If I shoot here, I'm damaging everywhere. All right? So you got to think about spleens, and you got to think about all those organs. This is what happens. Most often the spleen, because it's totally free floating as a child. Those babies just float around in there. The spleen. The liver, then the kidneys. The small intestines are one of your last things to be injured. You take a lot of force for that. So if it is, this is almost always inflicted. So if we have a hollow viscous injury, we always look for other signs of abuse. But these ones happen in motor vehicle crashes like all the time. But they always come together because they have a flexible pelvis. They will get referred shoulder pain. They'll be complaining of shoulder pain. Here's a funny one. If the kid over and over and over asks for water, and you say, sorry buddy, you can't drink, and all he wants is water, and he asks over and over and over again, he has a spleen injury. Don't know why. Something about the spleen causes a kid to want water like insanely. And I've asked our docs about it. I'm like, what is that? He goes, we have anecdotal evidence, but we don't have any medical reason for it. So they keep asking for water. Think spleen. Anytime you have bruising on the belly, you've got to think about these injuries as well, because bruising in general does not appear until about 2 to 3 hours after the injury. So if you go on scene and bruising is present, then you have to think that was incredible force. So you've got to think those organs are damaged. But the nice thing about the belly stuff and the blunt abdominal is 97% of the time it's non-operatively managed, which means that it's not an emergency in your ambulance. Unless there's active bleeding going on and you're worried about tamponade and stuff like that. Case study, 9-year-old female, high-speed front end collision, front seat restrained passenger, no airbag deployment, no loss of consciousness. Her vitals are stable. She's saying she has abdominal pain. She has abrasions and bruising. She's tender around the abdomen. And she has this. What's this? Seatbelt sign. Bruising on the scene. That's incredible force. So we give her some Zofran and fentanyl, and we take her to the trauma bay, and she's NPO, and we do some labs, and her white blood cell count's 10,000, and we admit her. And a couple of hours later, 10 hours later, she's febrile, she's tachycardic, she's nausea, vomiting, and she's talking about more pain, and her abdomen becomes firm. We check her blood count, and her white blood cells are up to 22,000. So they take her to the OR for an exploratory laparoscopy. And they find a puncture in her small intestine and a hematoma in her large intestine, a bruise. So just from the seatbelt, just from the force. Now again, this is a rare occurrence in kids because the bowel is the last thing to, or the least likely to be injured in an abdominal situation except for seatbelts. Here's another one, penetrating trauma. 11-year-old playing with a dog jumped onto his grandma's sofa and the knitting needle went into him, impaling himself with the knitting needle. So this is a wicked, awesome x-ray. He was totally stable. They transported him side-lying. They gave him morphine, which was really nice of him. If it looks like it hurts, it hurts. Treat pain. And then we did a trauma 1-up and took him to the OR where they cut it out. They removed it, and he did not hit one stinking organ. Not once. He was totally, completely fine. But here's the thing about penetrating injury, it's always the speed of the projectile that is the issue. So if it is a branch that is part of a motor vehicle crash and it was 60 miles an hour, that is going to do that little shocking thing we talked about where all the organs will be affected. Also, if it's a gunshot, obviously, that's their highest speed projectile that there is that we know about so far, that and shrapnel. That is going to affect all of our organs too. So it's a little different with kids. An adult can get through a gunshot wound with a pancreas injury. A kid will get through a gunshot, the same gunshot wound, same location with a pancreas, a spleen, and a bowel, and a liver injury. Because it just does this like thing. Okay? Any questions about that? Okay. Always, you guys know this, penetrating objects, secure it, keep it in place, all that. You guys know all that stuff. That has nothing to do with kids. So, key points for blunt internal trauma, stuff that you don't see on the outside. The internal trauma may not have visible signs and symptoms that you can see, but altered mental status is always an indicator that a kid is shunting his blood to his organs. So think about altered mental status as a sign of blunt trauma if you can't find any other injuries. And then again, here's that pesky little hypoxia and hypotension. I always want to say hypothermia. Hypotension. If you can stay on top of this for this patient, you increase their outcome. You improve their outcome. So really, really, really using that protocol, this right here is your approach to the pediatric patient and to the adult patient. Please, in me, prevent hypoxia and hypotension. All right, a couple of just pediatric pearls, guys. Kids have really strong elastic ligaments, which make them really super flexible. So they can get a lot of dislocations that adults just don't. This is a patella that was just, knocked off to the side. We get these all the time. This is rare, but Primary Children's gets every one of them from every place in the whole United States, it feels like. So we can see those all the time. And our doctors give pain medicine, sedation, and pop it in place and send them home. But remember that kids have active growth plates, males up until they're 16, girls up until they're 14. So they have growth plates that are still growing, and you don't want to damage those because it can damage their growth long term. You have to think about that. This kid was longboarding down a hill and hit a parked car. His leg did not look nice and normal. I liked a good marking. The EMS put a marking on his pulse, which was really nice because I could tell exactly where it was. But with your skeleton, obviously you guys know how to respond to a skeleton. You do want to consider that if it is a pediatric patient, they'll likely need a pediatric orthosurgeon, and Primary Children's has most of those. So Lehigh campus and Salt Lake campus would be your ideal place to bring a kid for that kind of, like anything in the growth spurt, anything on the long bones should be Primary Children's. Arms can be handled anywhere, the basic run-of-the-mill fingers, that sort of thing, whatever. But if you need an ortho consult, a pediatric ortho consult, you're gonna need to come to primary, or they should. Skin, again, we got some wicked skin stuff, but just all the same with everything. Here's the thing. One thing you need to know with kids is, and adults I guess too, they can bleed their entire 4 cans of blood volume out of a head injury. All right? They can. It's nasty. And it doesn't need to be this. It could be this. So you really do want to stop that bleed. Controlled bleeding, we think about antibiotics. We cover anything like this with a moist gauze and then a dry gauze. And then we do LET, which is the lidocaine epinephrine tetracaine jelly that we put on these things so that we can scrub them out. And we scrub them with we irrigate. This, 4 or 5 days ago, I clocked myself with a drill that got kickbacked right in my face. Total laceration, like all the way down my face. But I knew all of these tips, so I ran it under the water, I glued it, I steri-stripped it, I fixed it. Fast tracing, this really awesome stuff that I wish I had money in. It's called Active. But I put it all together, back together. That's what we do with all of these, and that's totally fine. Here's the thing I want you guys to take home with. If it looks like it hurts, treat it. We statistically do very poorly with pediatric pain control, all right, in the field and even in the ERs around the state. Kids hurt too, and we don't want to do math. We don't want to have to figure out that dosage for that fentanyl or morphine or whatever. So treat the pain. Use a tool. I hate math. I think I chose nursing partially because there was little math in it. But use a tool. We got a hand heavy tool. We got a PD stat. I love a good Broslow. If you can read it, if you have young eyes, you can read it. It works well. At Primary Children's, we squirt intranasal fentanyl into every kid's nose at triage who has a deformity. Because that's nice. Because we're about to put them on an x-ray machine, and we should be treating their pain. We should, and then we move to morphine once we put our line in. For sedation, we like it Versed, and then we move to ketamine. You guys have the EMS protocol guidelines, which are accepted by all your medical directors. Here it is. It has a whole section. How can EMTs treat pain? How can AEMTs treat pain? How can, that's it. How can paramedics treat pain? Use your protocols. Use what you have available to you, but treat it. If it looks like it hurts, treat it. Right? I'm all about the pain medicine. What's the worst that could happen? They lose their airway. You guys are airway experts who have a superpower in bagging. So what? Okay? Treat their pain. All right. Another just thing I think is kind of cool to remember. Kids hate the 60s. All right? 60 heart rate is bradycardia. 60 respiratory rate is tachypnea. 60 systolic is uncompensated shock and hypotension. And a blood sugar of 60 is borderline and probably needs to be treated. Kids hate the 60s. You're going to remember that more than you remember anything else I've told you today. But that's okay. I like this. This will give you some good action. This will help you prevent hypotension and hypoxia. Because of that respiratory rate. Okay? Kids hate the 60s. Okay, I told you we're going to talk about abuse. We are, briefly. I have an entire lecture on abuse. I have an entire lecture on TBI. I have an entire lecture on every pediatric topic you can think of. And it's not my lectures, it's my doc's lectures, and they're all at PTOS. Who's familiar with PTOS? Okay. PTOS is our monthly lecture series that's free. Offers free CME, and you can do it in your pajamas because it's on Zoom. And it offers incredible things. And my lecture presentation on child abuse is in it. So I'm going to give you the down and dirty. It happens everywhere, even in Fruit Heights. And you have to, unfortunately, approach every pediatric patient you come into contact with, from every kid in your ambulance to every kid at your community fair to every neighbor and every relative. Because you are a protector of children and you have to think about it, because statistically 1 in 5 children report that they were abused, and adults grow up and say 1 in 3 are abused. So that's a lot of kids. Now some kids might just think they were abused. Mine might, but they are not. So how do you screen for abuse on every kid that you come into contact with? You look for things that are very endemic of abuse. things that are like, that doesn't usually happen in the run of the mill. 10-4 faces is kind of the classic mnemonic for it. And these are kids that are 4 years and younger. Older kids can usually talk and they tend to have different wounds. But younger than 4 years, if they have bruises on their trunk, their ears, or their neck, more specifically, their frenulum, which is this little tissue under here, if I'm bruised up there, somebody's been forcing a bottle in my mouth or a pillow over my face, and I'm an infant or a toddler. If I have on the auricle, the ear, when I fall naturally, I automatically, with my honking head, hit with my head and my hand, and I protect my ear. That's a natural fall. So a bruise on an ear is typically inflicted in some way. Cheeks, eyes, sclera is the white of your eyes, and then any patterned bruising, okay? All of those are red flags. And then the other kicker is any kiddo that can't cruise is not bruising. So a kid that's 4 months old or less than 4 months old is not rolling off the bed. All right, they're not falling off a toy. You know, they're not moving, they shouldn't be bruised. So that's always a red flag. So you look for red flags. If you want a more thorough training and then you want to be gentle, watch my PTOS and get CME. If you want to not be gentle, go to our sister company, or our sister program. University of Colorado did this for their police force. It's a free training. It is good for 2 CME. You will see more pictures than you've ever wanted to in your life, but you will know what to look for when you come out of this training. Every single one of the people that take this in the surveys say that was life-changing for my ability to understand what I'm looking for with child abuse. So it's a really good training. I did take it. I was like, wow, this is picture overload. And you might have to cut it in half and do a little bit here and a little bit there. It's all computer-based and everything. But it is a really good training on understanding for first responders, like truly first responders, police officers, firefighters, EMTs, and paramedics. And then here's the thing: you're a mandated reporter. In your role as an EMT, or paramedic, you are mandated by law to report your suspicions or what you see in the field to DCSF. Protocols allow you to report to the ED physician or whatever. But technically, this Utah state law says you, an individual, are supposed to make your own phone call. And here's the thing about DCSF. I sit on the Child Fatality Review Board. I work with them. We review every child abuse case that progresses to death. Every one of those cases has some kind of interaction with an ER or a doctor's office or an EMT before that kid is dead. There's these spaces to be able to intervene. And here's how DCSF works, unfortunately, because they're completely underfunded. If you make a phone call and your partner makes a phone call and I in the ER make a phone call and the ED doc makes a phone call, that kid's higher priority. But if you report to me and I report to my doc and they make one phone call, less priority. So make your own phone calls. It's a voicemail you're going to get. You tell them your name, you tell them the kid's name and address and your suspicions. You never hear back from them. It's something that you should be doing on the regular if you have those suspicions. And don't worry, you're not putting, like, if you're in a smaller community, you know the family you're reporting, you're not automatically going to have that kid removed. They are big time pro keeping the kid with the family. Because even being beat, the child statistically does better staying with the family. They just have to educate and then watch the family to make sure that it's not continuing. But so you don't have to worry about the investigation or the whodunit or what happens to the child afterward, but your responsibility is to report it and document what you see and suspect. All right, final couple of things. EMSC is all about giving you quick and easy, down and dirty ways to learn about kids because, and here's my soapbox, you are never going to see enough kids to feel confident with pediatric patients. Which means you should be educating yourself on peds more often because you're not seeing enough. Why do we have training nights on adult chest pain? When you do that, that's your bread and butter, that's your muscle memory. We need to have education on peds. We need to be reminded of this stuff. And the way that we're doing this through EMSC is a monthly digital newsletter. We call it a bathroom read. We send this to everyone on Image Trends license, so y'all probably get it. Who has gotten it? Okay, who has it in their spam and needs to pull it out and open it every so often? We highlight PEDS topics, and it is bullet pointed. It is like this much information, but it will make you stronger in your pediatric care. And guess what? Everything you learn in PEDS is going to make you better in adults, because PEDS are the baseline healthy specimen. If we do it healthy, we can do it sick. So everything you learn, your efforts, in my opinion, as a PEDS educator of 30 years, is start with your PEDS education, strengthen that. Everything you do in kids and adults is going to make more sense. This newsletter can also provide you with CME, free CME. If your EMS instructor chooses to take that issue, review it with you, and do a skills check that's put in the newsletter, then you guys, every one of you will get issued 1 hour of CME. So the newsletter itself, just reviewing it, can get you CME, but you do have to do it through your training officers. If you're not on my distribution, if I'm in your spam, if you want it directly to me, email me, tdickson@utah.gov. But more fun is our lecture series. This is the Pediatric Emergency and Trauma Outreach Series. This thing's been going on for about 10 years. It's every second Monday of the month. It automatically, if you view it live, it gives you a CME certificate for 1 hour. You can use the CME, which is cool, for any pediatric topic, but you can also use it for whatever topic is being covered for National Registry. So, for example, this last one, we just did measles and infection, so you could do that for a medical topic for National Registry. These are on Zoom, and here's the kicker. Our archives are also good for CME. So you watch an archive one, you email this email address that is on the website, and you get a 3-question quiz, and then you get your CME from that. This is really popular right before everyone is recertain, because I'm like, oh man, because I'm the one who has to return all the quizzes and review them, and I'm like, oh man, it's March, or it's, whatever. I was like, ah. So, yeah, use it throughout the year, please. And come to the live ones, because they're way more fun. What this is this pediatric experts, usually the attending docs at primary, who are talking about a topic I've asked them to cover for you. All right, so this is interaction directly with you. We're averaging now about, I'd say 80 per month. But it's free education, and it's incredible stuff, and it's good stuff for you to learn. You can do it as a station, and then send in all your email addresses, and we'll send you all certificates. So here's the thing with my archives. You go on a bad seizure case for a kid, and it's sticking in your head, and it's grinding on you. Dr. Maya Holste, one of our attendings, did an incredible pediatric seizure lecture on status epilepticus. That is something you should watch while you're digesting that patient that you had. There's tons of trauma topics. We have our Robert Swindeman, who's the lead trauma surgeon at Lehigh Campus Primary Children's, did a blunt abdominal trauma that was like mind-blowing. All of these are on this website. So go use these archives, strengthen your pediatric care. Ask me any questions that you have. And here's the other thing. Primary Children's Forever was the black hole. You guys would bring a patient to primary and you would get nothing back. Now we have a follow-up process. It's a little more complicated than it needs to be. But I give direct follow-up on all medical cases. This woman, Catherine Stokes, is the outreach for trauma, and she does all trauma cases. So if you are a person who took a kid to primary and wants to know what happened to that kid, you can direct email me with these QR codes. This is in our newsletter every month. You can print it out, post it all over your station, and you can directly contact me. I just need to verify that you were actually part of the patient's case and care, and I'll tell you what happened to them at primary. It's nice, though, if you go through your training officer, because then I get to know their names. I don't have to do quite so much credential checking. So you can also shoot your training officer a email, and then I can give the information to them, and I'm a little bit more and I recognize them. You should also be aware that Salt Lake Campus, Ellen Rainwater, it's actually about to be changed to a guy named Ben. and Lehigh Campus, Kylie, these are their official liaisons. They're the ones who, you know, I'm missing a piece of equipment, you cut my equipment, that nurse was mean to me. That is those sorts of feedback and that kind of communication loop. That's more directly related to hospital care and your guys' relationship. But Catherine and I will do a couple of different ways with our follow-ups. We will email you a quick little synopsis of what happened, if it's a run-of-the-mill kind of a case. Or if it's a big case and things may need quality improvement, or it's really bothering you, or you didn't like the way things went, or you feel uncomfortable about how it did, we'll come to you, just like this scenario. We'll run through the case from scene to discharge, and we'll go through every element with you, and we'll bring people. We'll bring my attending physician or the Lifeline people or whatever people need to be brought. Or sometimes it's just me. But we review cases with you just for your own QI and comfort. We want you guys to be comfortable with primary children's. We want you to be comfortable with patients that go to primary children's. And not just be a black hole that you can't close the loop on, because we recognize that you guys are a huge part of our team, and it hasn't always been historically treated that way, which is like, it's like a thing. So that is available to you. I am available to you as a resource at primary. Just let me know, whatever you need. What questions do you have? What did I not cover that you've always worried about with kids?
I do have one, and it's kind of back in the TBI stuff.
Mm-hmm.
When you're doing your neuro exams and when you're doing your repeat neuros, what are you doing for like different ages and different things like that, and their understanding developmentally? Does that make sense?
You mean what kind of like questions or evaluations
like
you're
questions
doing?
are you know, because for us it's a Cincinnati, it's a squeeze my hands, it's a talk to me, you know, kids.
I would say those tools that you just used right there.
Yeah.
And I would, if you have any familiarity with kids at all, you're going to talk to them about their interests.
Right.
So if you know that a toddler should be loving Mickey's Clubhouse and that a 8-year-old should be loving Phineas and Ferb, you know, things like this that you, and it's always entertainment, by the way. And pain distraction is also really good. TV, phones. It's one time I will pull out my screen. It's in the back of an ambulance for a kid, for developmental stuff. But specific tools, it's the same thing. It's squeezing my hands. I'll use bubbles if I want them to breathe deep. You know, or I'll have them blow a pinwheel. I have a little mini pinwheel that I'll have them breathe for. There's all sorts of little tips and stuff like that. In PTOS, we have one that they just did that was distractions and holds. So it talks about the best ways to distract kids, the best ways to interact with them on a developmental level. As far as specific neuro tasks, though, it's the same as adults. I want to check both sides of the brain are working, so both hands and feet, pressure and push, and then they're alert and oriented to their own developmental stuff. I am going to expect a toddler to cry, but is he consolable? Does mommy near calm him? That's a good developmental sign. If he's unconsolable, I'm concerned. And it's outlined in the GCS there too.
Okay.
Great question. Other questions, guys?
Any chance you can get a copy of your PowerPoint?
You can have it. Well, she can have it and do whatever she wants with it. Yeah, absolutely.
I just recorded this too.
Cool.
Yeah. But again, PTOS, guys, that's where it's at. It breaks everything. I gave you this, like, are we about to fall down?
Maybe.
I gave you this, like, this is a summary of one of the biggest topics of trauma, of pediatrics. We break it down to little bits and pieces in PTOS and awesome lectures. So come and join us. Have fun. All right, thank you very much.
Thank
You're
you.
done.
Vehicle into the building.
Great.
Yeah.